Our next speaker is Aaron Clark, speaking on frailty and minimally invasive spine surgery, predicting outcomes, and he is an associate professor at UCSF.
Thank you all very much. Thank you to Chris and Vdara for inviting me. Again, my talk is really going to center around MIS surgery. Just by way of background, last year I was kind of bemoaning, both publicly and to Chris, that I was only one of two MIS talks in this high-profile deformity meeting. And being the empathetic man that we know and love, this year Chris changed the schedule, so now I'm the only MIS surgeon. So thank you, Chris. Couple disclosures, none of which are relevant to this talk, but one that is relevant to this talk is I do have a 1-month-old at home, so if you see me just staring blankly off into space, someone please yell at me, okay? Just a little bit of history here. As we all know, the TLIF approach as we know it now was described first in its open form by Jürgen Harms in '98. Just based on some of his sketches in this initial paper, you can see that it's a traditional open approach and fairly significant soft tissue disruption associated with getting the exposure needed. My mentor, Dr. Foley, in Memphis, he described just actually a year or so before that, the first description of a minimally invasive approach to the spine using the tubular retractor in its initial form, endoscopy, to form the first microdiscectomies. This really ushered in the initial era of minimally invasive spine surgery. He followed that up in 2001 with the first descriptions of the PERC screws, and so this started the push towards more and more minimally invasive fusions. Some of the principles behind this is minimizing soft tissue disruption in gaining that exposure that we need to the spine. Figure C here from this paper from Australia shows the traditional approach with some significant soft tissue disruption, and if you put this from a more paramedian approach using a tube and muscular dilators, you get significantly less paraspinal muscle disruption. Same principles apply to minimally invasive fusions. We're using natural tissue planes. You not only minimize the size of the incision, but also the soft tissue disruption, particularly related to the paraspinal musculature. Another paper out of Australia here. My typical protocol doing MIS is for a single level decompression. It's about a 16 millimeter incision, and sequentially larger incisions if I'm doing fusions, moving from 1 to about 1 3/4 inches up to 3 levels of fusion. When you get beyond that, you end up doing a lot of little stab incisions because there's so much distance between the incisions. Now that's great from a cosmetics standpoint and theoretically better from a soft tissue disruption standpoint, but is it associated with lower complications? When I was a fellow, I was involved in this study. This is a meta-analysis of all the larger studies of minimally invasive TLIF versus open TLIF. It's about 1,000 patients in each group when you combine them all together. There was one randomized controlled clinical trial and then prospective, and the majority were retrospective studies. And what we did find, among other things, was when you compared all of these studies, is actually there was a significantly lower rate of complications in the MIS TLIF group compared to the open TLIF group, and this held up to statistical analysis. So particularly working with Chris and all of his work that he's pioneered with respect to frailty in spine surgery, I was wondering, are there certain groups that derive more benefit from an MIS or a tissue-sparing approach compared to the traditional open approach? And I did want to focus on frailty. Just by way of definitions, it is defined as a medical syndrome with multiple causes and contributors that is characterized by diminished strength, endurance, and reduced physiologic function that increases an individual's vulnerability for developing increased dependency and or death. Basically a measure of physiologic reserve and the ability to recover from an insult, such as a surgical procedure. It's fairly prevalent, not only in younger group, but as you get older, the prevalence of frailty increases pretty rapidly. When the ISSG created the first spine-specific frailty index, which is called the ASD, or Adult Spinal Deformity Frailty Index, they really wanted to look at these principles. Number one, it had to be related to health status, increase with age, doesn't saturate early, and also covers a wide range of symptoms, and it really needs to be about 30 or 40 variables. And so ultimately, finding overlap of multiple pre-existing frailty indices, they came up with the spine-specific frailty index, and this ended up being 40 variables, small print here, but ultimately things that we really do care about with respect to spine surgery. And this was published in Neurosurgical Focus, and it really did hold up in that when you stratify patients based on non-frailty or increasing severity of frailty, they did report increased risk of complications, at least in deformity surgery. This predicted all the major complications that you'd expect from deformity surgery: PJK, wound infection, pseudarthrosis, and also hospital length of stay. When thinking about frailty, it does have to be paired with an invasiveness index, and so the ISSG came up also with an adult spinal deformity invasiveness index, significantly outperformed some of the pre-existing non-deformity specific invasiveness indices, and this was published in Neurosurgery. Taking that one step further, I did want to look and see if this adult spinal deformity index did apply to the minimally invasive population. And so I did a study on this, focusing again on minimally invasive TLIFs. This was recently published in Neurosurgery. And it was a retrospective study, 115 patients, 44 patients in the MIS group, 71 patients in the open group. I applied the ASD frailty index to all these patients and looked at outcome, including discharge location, need for revision surgery, and hospital length of stay, performed univariate and multivariate analyses here. Standard indications for TLIF in both of these groups. And overall, fairly well matched. There's a little bit, there was a statistically significantly younger group of patients in the MIS group compared to the open group. And actually a little bit more comorbidities in the MIS group, kind of counterintuitively, or a trend towards that, and a trend towards less previous surgery in the MIS group, but those were both non-significant. In outcomes, we did find that there were significant differences with respect to percentage revision surgery, hospital length of stay, and percentage discharge to locations other than home, all favoring the MIS group. And in looking a little bit more deeply into this, when we looked at the potential causes for this, at least in univariate analysis, patient frailty was statistically significant, as well as performing this surgery minimally invasively was also associated with a decreased need for revision surgery. Same trends were true for discharge location, so in other words, discharge to any location other than home. Frailty impacted that, as well as if the surgery was done minimally invasively. On multivariate analysis to look for independent predictors of revision surgery, the frailty index did hold up to this test as well. So it was an independent predictor of need for revision surgery in this group. The reason for revisions were, as you can see here, pretty standard and well distributed amongst known need for revision surgeries. And same thing for discharge. So the frailty index, the SDFI, was still an independent predictor of discharge location. Now, comparing all of these things together and looking at both discharge location as well as need for revision surgery, what we found was that if you look just at the open groups, comparing frail to not frail, there are significant differences here. So the frail patients, if they had an open TLIF, were significantly more likely to have revision surgery and significantly more likely to discharge to somewhere other than home if they had open TLIF. But then if you look at the bars for MIS surgery, when you compare either non-frail or frail patients, it actually leveled the playing field here. So these patients were not at increased risk for needing revision surgery, and also they were not at increased risk of needing to go to rehab or a SNF after surgery, showing that these patients may have a differential benefit if the surgery is done minimally invasively compared to open. Here's one case example that I think highlights this. This is a 79-year-old patient of mine. He had multiple medical problems, ASA3. When you tally it up, he was obviously in the frail group. He had low back pain, left leg pain, and left leg weakness. And looking at his imaging, he clearly has some global spinal problems, but he also has severe stenosis at L2-3 and L3-4 and a spondylolisthesis at L4-5. And so rather than subject this frail patient to more invasive, large reconstructive surgery, I decided to do an L2, 3, and 3, 4 minimally invasive decompression. And then at the level of instability, I did a minimally invasive TLIF at L4-5, just a little bit about the setup that we all know through a 22 millimeter tube. Using navigation, and this patient stayed in the hospital 2 days after surgery, and he went home. He didn't go to rehab. So, in conclusion, for this part of the study, the ASD Frailty Index, it is disease specific. It's the only spine specific frailty index that we have. It can predict outcomes in spine surgery. What we've shown is that minimally invasive TLIF at least has lower complications compared to open TLIF, and frail patients have higher complications compared to non-frail patients after open TLIF, but that difference disappears when you look at patients undergoing minimally invasive TLIF. And ultimately what I take from this is that at least it's reasonable to consider minimally invasive options in frail patients who do need a fusion. Now, following up on that, I was interested if we could expand the indications for patients that may be candidates for minimally invasive TLIF type operations, particularly if they're frail, since we now know that there is perhaps we know that there is a benefit, particularly in the frail patients. And I became interested in treating adjacent level disease minimally invasively. Recently submitted this paper that I worked on with some of our residents, past residents, and one of our interns. We know adjacent level disease is a problem about 2% per year after a fusion. And in general, it's an indication for an open extension of that decompression fusion to address that. I'm going to, for the sake of time, I'm going to move through this a little bit quickly, but for the paper submission, we did make a little video to highlight the technique. It involves this patient who's 80 years old, certainly frail, has had an L3 to 5 fusion and an even more distant solid fusion at L5S1. He's CT confirmed solid fusion through all of those areas, but you can see at the level above the fusion, he does have a severely degenerative disc. He has severe foraminal stenosis bilaterally that's symptomatic, and he's failed conservative management. And so the hope was to, since he's frail, to be able to derive some of those benefits, get him down to a more reasonable risk of complications, and perform this minimally invasively if possible. And in the technique that we use, it initially starts with our standard paramedian incisions, minimally invasively with navigation. We use navigation to identify the prior construct and incorporate that into the incision. And then this video is going to show using the tubular retractor placed over the screws and rods. You can actually, let me get to the video part. You can expose the screws very easily. This is through an 18 millimeter tube. Ultimately, placing instruments here, removing the screws. Since it's solidly fused, you don't need to replace the areas that are fused, but you do drop a K-wire into the superior level so that you can incorporate that into the subsequent fusion. Ultimately, remove the rod, and then perform a standard minimally invasive TLIF at the level above. This just shows a pedicle screw coming out under the microscope. And this last schematic here, this is the ultimate final construct. So hardware has been removed through the solid construct, and then minimally invasive TLIF has been performed at the level above. This is all done through 2 1-inch incisions. And this shows a little bit about how you can do that. Based on lordosis, you can actually get the tube to address all of these hardware removal, as well as doing the operation all through a single 1-inch incision. One second. Some of our results here, this was 14 patients. 9 of the patients just had single-level removal, single-level minimally invasive TLIF. A handful of them had multi-level constructs. Overall, they were in the ASA 2 to 3 range. And if you look at their medical problems and tally that up, most of these patients were frail. Followed them on average for about 9 months. There's one hematoma that had to be evacuated at the operative area, but overall, as we did more and more of these, the length of time of the operation went down. No other reoperations during the study period, and overall, looking at postoperative radiographic measurements, these patients stayed fairly well balanced. So it's not a deformity operation, but in the frail patients where you want to do a decompression fusion for the adjacent level, you can at least keep them where they need to be. So in conclusion, MIS hardware removal and adjacent segment minimally invasive TLIF can be done safely and efficiently. And it's just something to consider in your frail patients that have adjacent level stenosis above a solid fusion. This is an additional option to be able to treat these patients minimally invasively. Thank you.